Now that we have seen the advantage of basal insulin and basal plus regimen and how to use it in our clinical practice, we'll just look into the other regimens, how to incorporate in the same patient. So the disadvantage of basal plus regimen is it is two insulins that you are giving. So one is like the patient is taking a basal insulin, the other is the patient is taking a meal correction also. So the patient goes with two insulins which patient may not like. So that is the biggest disadvantage of basal plus therapy. The second disadvantage is being cost. So both the basal insulin as well as the prandial correction also may be expensive for in a resource poor setting. So it may make it unsuited for certain group of patients. In that case, we can think about the other regimen, which is the premix regimen. We saw about what is the premix regimen that are available in our clinical practice. So how will you calculate the premix dose regimen? So there are two cases, there can be two scenarios which can happen over here. So you can directly start the patient who is on insulin naive. So the patient is not on any insulin. So here in this particular case, what we are doing is the patient is totally insulin naive. Basal insulin he is not able to afford. So in that case, we can start him with premix insulin. Or the patient is already on glargine, then the patient's sugars are like this, and the patient may need, instead of basal plus therapy, we may need to switch the patient to premix insulin. So these are the two scenarios which can come when we talk about premix insulin. How are we going to calculate the dose in this patient? So again, the rough formulas, we can retain the same that we have discussed. So the patient is already taking 24 units of glargine and his fasting is about 255. So use the same formula that we discussed. 255 minus 100 divided by 10, which is about 155 by 10. Then number of units required is about 15 units. So already the patient is taking 24. So the patient will require now about 39 units of insulin. So of which the 39 units give 2/3 of the premix dose with the breakfast and 1/3 at night. So the patient will require about 26 units in the morning and 13 units at night. Very simple, easy to calculate, and I will tell you like how to adjust the dose of insulin a few minutes later, but hope it is made clear. So easily we can switch the patient from glargine to premix based on this formula. So you require how much units the patient needs extra. Add it to the already taken units of glargine. So that is the maximum dose that the patient needs, and the patient has to be given 2/3 with breakfast and 1/3 at night. So if the patient develops hypoglycemia, based on the time of hypoglycemia that the patient is getting, we can down titrate the regimen accordingly, that we will see shortly. So this is how the patient can be switched from glargine to premix. Now the patient is insulin naive. The patient is not taking any insulin. How are we going to do the calculation? Again the same formula. The fasting blood sugar is 255 minus 100. It is 155 by 10. So it is 15 units, 2/3, 10 units with the breakfast and 1/3 at night. Here we don't need to add that 24 because like the patient is not on any insulin. So very, very simple. No, 255 minus 100 by 10, 15, 10 in with the breakfast and 5 at night. So that is what the patient needs. So easy to calculate and easy to work also. So titration or switching from glargine to premix insulin is so easier when we are doing with premix insulin if you use this formula, and how to split between breakfast and dinner. So we can do it easily. Now the most important thing as far the premix insulin is concerned is how am I going to titrate the doses of insulin. That is very, very important, which becomes a bit difficult also, provided if you can understand this concept, it is made much more easier. So when the patient is taking premix insulin of about 30-70, like we said, like 26 units or 13 units in the morning and dinner. So of which, so if the patient is taking a premix insulin, of which 30% is short acting and 70% is long acting. So the short acting, where does the short acting function works? So you give the premix insulin before the breakfast. The short acting insulin will have its action for about 4 to 6 hours. So with a actrapid. So where does the action of this short-acting component of the premix insulin ends? It ends just before his lunch. So, see a blood sugar before lunch rather than post-breakfast. See it whether the insulin action is completed over here or not. So that is what is very, very important. Don't concentrate on post-breakfast. Rather, it should be pre-lunch to see the action of short-acting insulin. Where does the action of NPH act? It can act till even 18 hours. So you can see the action at least before dinner where the insulin action ends, NPH action ends. So this will give an idea about whether the short-acting component is working fine and the long-acting component is working fine by seeing the sugars over here at 1 o'clock and before dinner. So how are we going to monitor this patient who is on premix insulin?